Start the program. What at me?
Okay.
Yeah.
Good evening, everybody. Today we have a very important topic and a person who's well known across the country for his acumen in infectious diseases, Dr. Ashwini Sood, who's going to talk on antimicrobial therapy and on stewardship in clinical practice. To chair and to moderate the session, we have two experts. Dr. Tapisha Kumar, who's a consultant pediatrician and is working in Max Patpatganj as a consultant. Uh, uh, Dr. Tapisha is a well known person across the country for her work in infectious disease. And we also have Dr. Anavita Agarwal, who is a DM in infectious diseases and trained at All India Institute of Medical Sciences. And for the last 2.5 years, she's been working with Sir Gangaram Hospital. We are happy to welcome her in Gangaram Hospital because uh, we didn't have a trained person in infectious diseases, uh, formally trained person rather. There are people who are having interest in infectious diseases, both on the pediatric and the adult side. But Anavita is the first formally trained person, and she acts as a bridge between the microbiology and the clinicians also. And so, welcome both of you. And may I request Dr.
Thank you.
Tapisha to please introduce Dr. Ashwini Sood, and then we can start off the topic.
Sure, sir. So good evening, everyone. And I welcome Professor Ashwini Sood. I know him for the last so many years. He's done stellar work in rickettsial diseases following his huge experience at Shimla. Now, sir is at Haryana. He's the medical superintendent at Institute of Medical Sciences and Research. For the last so many years, he has taken the lead in treatment and reporting of rickettsial diseases and many other infectious diseases. I welcome him and I invite him to start the session. Professor Ashwini Sood.
Thank you, Tapisha. And before I start with the today's presentation, I'd like to convey my regards to Delhi IAP and Institute Child Health for giving me this opportunity. So today's topic is antimicrobial resistance and stewardship in clinical practice. So I'll take you over next 50 minutes, some important demographics and some disturbing trends also. So before I start, I have one quote, which is one Nobel laureate, Dr. Joshua. He was awarded this Nobel Prize in way back in 1958 in medicine and physiology, and he said that future of humanity and microbes will likely evolve as episodes of our wits versus their genes. So he had been working in AI at that time when I was going through this. And with this, I'm going to open the talk and let's go back to 1928 when Sir Alexander Fleming discovered penicillin and he got again prize in 1945. So we can have just one small clipping from New York Times. The microbes are educated to resist penicillin and a host of penicillin fast organisms are bred out. In such cases, the thoughtless person playing with the penicillin is morally responsible for the death of a man, and so on, so on. And probably this is the reason that today we have to discuss. And if you want to talk about in most of the countries, there are full-fledged department in infectious diseases who are going to take care of antimicrobial resistance. So what is this antimicrobial resistance or AMR, which we all talk about? This is resistant to an antibiotic means that that very particular drug is no longer effective against the infective bacteria. And as we all know, this could be both intrinsic or acquired. We will learn in the subsequent slides, and these are few examples. Everybody who was working in infectious diseases, like we are well versed with MRSA because we know that cannot be treated with cloxacillin. Then we have VRE or vancomycin resistant enterococci. And then we have CRE, which has become resistant because we are not going to use meropenem, is not going to be effective there. So there are certain basic facts before I start. There's change in antimicrobial use is going to lead in a change in resistance patterns. And if you want to look into the data, resistance is more common in healthcare acquired or associated infection versus community acquired. And patients with resistant hospital acquired infections are most likely to have received most of the time some previous antimicrobial therapy. And it has been shown that those institutions which use rather misuse higher antimicrobials, there are high rates of resistance in hospital acquired infections. And finally, it's very important to understand that longer a patient is exposed to an antimicrobial, the more likely he or she will become colonized with an organism that is resistant to that antimicrobial. And this becomes important when antibiotics are not warranted and these patients are provided antibiotics for a long, long time. So if you look into these 2019 WHO document, so 1.27 million deaths per year directly caused by bacterial antimicrobial resistance. And if you want to add on, then more than the HIV, TB, and malaria. And unfortunately for children, if you want to look here, as per WHO 2022 statistics, one child dies every 3 minutes from multi-drug resistant sepsis. So this is basically a very serious issue to work over. And let's have, because we every time talk about GDP. So if you are going to take this antimicrobial resistance is going to reduce the GDP by 3.8% in WHO estimates. And that can lead to 10 million deaths by 2050. And you can see the cost is around 66 trillion. So this basically very disturbing figures. So we all know there are superbugs starting from 1950 when the antibiotics has been started to be in widespread use. And 1962 was the year when we have first case of MRSA from UK. And then it becomes that almost 100 trillion is going to the cost. So this is a 2023 very good review article in Lancet. And we can see here that global deaths which are going to be associated with bacterial resistance by infections. So we can see lower respiratory tract infections. And there are two issues here. One is associated with the resistance, this one, and the darker one are attributable to resistance. So if you want to combine them together, we can see in all spectrum of diseases, they are going to be higher. And the same article, when you would like to go through that, you can find out that in Asia, so we have a very high version of these antimicrobial resistance associated either with resistance or attributed to the resistance. And this clipping I had taken from Times of India, you can see that current value, this MR to be leading cause of death by 2050, and it is going to mask the rest of the diseases. So in India, what we are having very high disease burden. We all know there is every day we come across there's drug resistance is rising, and there are a number of innumerate challenges in the healthcare settings because almost all hospital, at least in public facility, are overcrowded, economic burden, then impact of vulnerable population. We are having now more and more elderly and population, and there is widespread misuse of antibiotic in agriculture. And we all know that for last 25 years, only very new limited antibiotics has been come up. So what is happening? India is under the superbug threat, and that's why we need to be very careful and try to look into. So this cartoon gives us an idea that what is happening. Now these bugs are not scared of antibiotics because they are just nobody can stop them because we are misusing and overusing all these antibiotics. So these are the 10 most common, and even we can see the latest reports from US, starting from Nigeria, and we are all know that Acinetobacter has become resistant to most of the drugs which were used to be work against that. So how does it happen? So this is, we use antibiotic use in feed to prevent the to promote the growth and prevent disease. Then it goes to animal husbandry or poultry, and there's emergence of multi-drug resistant pathogens. And so what happens? There are antibiotic resistant infections. It's not only the misuse or overuse of antibacterials. Bacteria or these all bugs, they do have intrinsic genetic mutation property, which is going to lead to multiply. So what happens, like in my ICU, NICU, I'm going to use a particular antibiotic, which is not going to take care of few of the bugs which are there. So because of the plasmid resistance, they are going to develop mutations. So ultimately, end of the day, I'm going to have all those multi-drug resistant bugs in my ICU. So this cartoon again show that there are a number of issues. So bacteria, contaminated water, and everywhere they are around us. So what is its implication? So we need say there are around 1.7 million adults that develop sepsis each year. And unfortunately, if it is because of the hospital require multi-drug resistance, then the cost goes multiple times high. Then we have women around 1 to 1.2 million who undergo cesarean section, and we all know most of the time they are given antibacterials. Then chronic conditions like diabetes, they are all predisposed. And finally, we have these patients who are immunocompromised, like organ transplant or who underwent dialysis or for cancer care, they are at high risk. So let's try to understand what is use. So use is the use of average antibiotic dose prescribed, and this is primarily used to help the heal the illness. And then we have uh, misuse. Misuse is a substance for a purpose which is not consistent with the legal or medical guidelines, as we all know. And finally is the abuse. Substance abuse refer to the harmful or hazardous use of either psychoactive substances, which include alcohol or illicit drugs. And if you are going to take too much of that, that is again abuse. So what happens when we are, how these superbugs are there? So we have a poor infection prevention and control practices. If you want to look into the best of the facilities, the hand hygiene statics are not good, not beyond 60%. Then, as we discussed earlier, there's going to be natural selection and adaptation, then antibiotic use and misuse. And most of the time, when as we talk about outdoor practices, treatment is incomplete, or that antibiotic is used again and used in agriculture, and we do not have at most of the places effective disposable mechanism. So when we were talking about the intrinsic resistant of bacteria, let's try to look into this. Is important to understand that some bugs like gram-positive pathogens, they are not going to be taken care by astronome or colistin. Similarly, glycopeptide and oxazolidones and daptomycin not going to be effective against gram-negative pathogens. And what we see at most of the time, meropenem and vancomycin is misused, rather like that has become the standard line of treatment as late in neonatal ICUs or in pediatric ICUs. We hardly care for the bugs. So similarly, Acinetobacter, staph, anaerobes, serratia, Klebsiella, proteus, they are not going to be taken care of by these hormones. So there is some gut bacteria which may have resistance to beta lactams. And then what happens as we started using more and more of beta lactams, the bugs come up with their extended spectrum beta lactamase, which is going to denature those. And finally, it has been shown that the Pseudomonas is an opportunistic gram-negative pathogen which is responsible for large number of organisms. So this table gives us and that like Klebsiella pneumonia, they have become resistant to carbapenem antibiotics. Mycobacterium, we have a good number of patients presenting with MDR-TB. Similarly, for E. coli and Klebsiella, Staph aureus, even for skin infections, and what to talk about, Neisseria gonorrhea. So these are basically how this happens. This is a continuous chain going on in the universe. There is a sources of antibiotic resistance, how we are going to get across, so one need to be taken care of. So how it is transmitted, we know this is plasmid. Then there are mobile genetic elements, aegis, transduction, conjugation. These are the processes going on. These are more of resources that either these antibiotics are inactivated, or like for penicillin, how the penicillin binding protein is going to take care of these bugs, but that there is going to be alteration in the site, or the bugs are going to develop a facility for reflux. They will just spill out reflux the antibacterial. So it's different to understand because there is going to be selection pressure, mutations. So because everybody would like to strive in this environment. So what happens when we have initially we have one bug with spontaneous antibacterial resistant, then antibiotic is present. So ultimately, 2 generations later, it starts multiplying, and you can see in the end that we have more of the bugs who are resistant to most of the drug, that is multi-drug resistant. So where we are having these bugs, we can have in healthcare facilities, in communities, water and soil, food supply, and around the world. So this is a time frame which shows from the year 1941, as this was released. We started getting 1942 penicillin resistant, and if you want to look into 2015, ceftriaxone every victim was licensed, and we at the same year in 2015 you can find out that KBC producing Klebsiella pneumonia was there. So these bugs are going to take care of all these. Then there is a mechanism of biofilms. We all know that these biofilms does not let the antibacterial act at the side. So this is a long list of superbugs, starting from multi-drug resistant Acinetobacter to drug-resistant Mycobacterium. So now let's briefly come to the topic that how we are going to take care of what is antimicrobial stewardship, why it is important. So what is stewardship is systemic approach to optimize selection, doses, route and duration of antimicrobial treatment. Ultimately, so what we are going to get, we would like to reduce the inappropriate antimicrobial use. We would like to have the desired outcome of improved patient outcomes and reduce adverse consequences of antimicrobials. And at the same time, we would like to make an effort to reduce the development of multi-resistant organisms. Because we all know that inappropriate prescribing is also associated in addition to this resistance to antimicrobial allergy or treatment toxicity or infection with Clostridium difficile and content. So these are the pillars of antimicrobial stewardship: right antibiotic, right patient, right time, right dose, right route, and right duration. We are going to learn in them. Antibiotic use contributes because if you are using in even in appropriate therapeutic doses, it contributes to the development of antibiotic resistance. And like in those patients, because we would like to minimize the risk of infection in surgery and cancer patients. So infection rate can be brought below 2%. But if you are not having effective antibiotics, or unfortunately the patient gets infection from the multi-drug resistant, that this could reach up to 50%. So what is its outcome to the society and to the patient and the healthcare system? The cost is going to be multifactorial. So this is a mechanism how these bugs they are going to develop. And then we have, this is the organization OECD. They have come up in Australia that between 2015 and 2050, that in Australia alone, around 10,000 more people are going to die every year because of antimicrobial resistance. And let's come back to this gentleman. He also said way back when he had discovered penicillin, that the thoughtless person playing with the penicillin treatment will be morally responsible for the death of the man who comes to the infection with the penicillin-resistant organism. So we were also aware way back when he discovered the penicillin that tomorrow the scene is going to be like this. So antiviral stewardship, which we are going to discuss by promoting the selection of optimal antimicrobial drug regimen, dose, duration of therapy, and route of administration. And at the same time, we will try to achieve optimal clinical outcomes. So it is basically to improve the patient outcomes and to minimize the adverse and unintended consequences, at the same time being cost effective. So how this AMS came up? Let's briefly go through this one old document from IDSA. So they have in 2001 guideline, then came up CDC elements of antimicrobial stewardship in 2014, and then the first report of PCAST in 2014, then action plan in different places. IDSA came with the guidelines, and finally more antimicrobials. So it was now decided to have antibiotic stewardship core elements in for all small and critical access hospitals to take care of antimicrobial resistance. So how this resistance is going to be there? If we are going to have expose a patient to the suboptimal levels of antimicrobials or the microbes carrying resistant genes, like patient is not going to get effective dosing. And what happens at the time of the patients? We all know that in India, we can have those uh, over the counter, and for 1 or 2 days, they are going to some counter and taking some antibacterial, whether it is not warranted or not. And we have seen this much in COVID when a patient has been given 3 and 4 antibacterial during COVID-19. So prescriptions not taken correctly. Antibiotics for viral infection most of the time, and antibiotics are available without medical supervision, and there are lack of hygiene and hand washing practices, which is going to lead to the spread of resistant microbes. Or at the same time, we daily come across newspaper report that certain antibacterials or other medication which has been manufactured in a particular plant or has been found to be sub-quality or outdated antimicrobials. And we have definitely there's some lag in the surveillance system, and or at times because of poverty or war and antibiotic in food, which we already learned. And we all know that these are misused in animal feed. And this is one of the report from US, where the multi-drug resistant Salmonella typhi has been reported in 4 states in who are beef-fed antibiotics. So this is one interesting study which show that how we are doing it. We can find out. I'm sorry for the poor because this slide. So we can see more than 30%, and in common cold around 100%. Bronchitis 80%. So we can see right from their had antibiotics has been overprescribed, whether they were not warranted. So cost of treating multi-drug resistant TB, if you want to see, if you are going to treat with second and third line, it increases from the first line to around 9,000. So increased cost of treatment, and then we all know this is the biggest MRSA, and this is one study from one of the ICU in India itself that 25% critically ill patient required infections, and we can see Acinetobacter multi-drug resistant to the tune of 92%. And most likely, we are not going to start the empiric antibiotic in appropriate doses for around 50% of the patients or organism. So that's another reason in ICU. We'll learn later on. But there are certain reasons why in ICU we cannot have those antimicrobial stewardship until unless the whole of the unit who is managing the ICU are well convinced. So in another study which has come up, that ICU infection rate is around 30%, and they have reported by high resistance rate to cephalosporin like cefixime, cefodoxime, to all these bugs. So how we are going to, why is public health concern? Because antimicrobial resistance is a very big concern as a public health. Though, because why we are not understanding it? Understanding because I see 1 or 2 patients, 3 or 4 patients. But when we want to take about in whole of the India and whole of the hospital in the population, then we will find out that how much is the burden. And we all know we are going to give rise to superbugs daily, but we are not having newer effective antibiotics which are going to take care. And it has been shown in National Healthcare Safety Network that the resistant doubles even within 2 years. So that's basically, and here we can see that resistant against MRSA, we already discussed this mycin-resistant enterococci, then fluoroquine-resistant pseudomonas, how they are going to rise by leap and bounds. And we all know there are hardly new molecules, so bad bugs and no drugs, and revenge of the killer microbe, they are going to take care of us. So in what is happening in hospitalized patient, most of the time there is heavy use of antibiotics. These patients come to second or third facility already been exposed to antibiotics, invasive devices, and then prolonged length of hospital stay because of comorbidities. They are immune suppressed, maybe diabetic, or maybe having some other reason, malnutrition, and sometimes cross contamination because most of the hospital where it is overcrowded, they generally do lack in the infection control measures. And most another factor is that inadequate therapy, and that is defined as when we are using a particular antibiotic, which is not going to cover the infective pathogen. Like I'm going to treat streptococcus sore throat, but as we see most of the prescription, they will going to mention the azithromycin, or the pathogen already been resistant to the antibiotic. If I'm going to use treat Salmonella typhi, which is resistant to ceftriaxone, then I don't have except any option against azithromycin. And most of the time, dosing is not optimum. There are multiple factors. Either it is not prescribed or patients are not going to take in the desired doses. Combination therapy is, if it is indicated, then it is not used. So what is the impact of this resistance? Higher medical cost, longer length of ICU in hospital stays, and definitely it is going to reflect in the higher mortality rates. So let's see one example, like take an example of anti-diabetic or anti-hypertensive. They are given to the patients. There's clinical effect of toxicity and drug going to effect is stop here. But which we forget most of the time with antibiotics, what is going to happen? Antibiotics given to the patient. So either this is going to eradicate or the microbe is going to develop a resistance. So most of the time, if you are going to use inappropriately antibiotic, so it is going to lead to the treatment failure, colonize patient, environment, and transmit to other patients. So that's a biggest worry. So we need to look into that. Already this pipeline is not there, and from 1930s, we are going to have very new antibiotics are very less. So this is also known as tragedy of commons, that now in a particular patient, that particular antibacterial is going to be effective, but when you're going to talk about patient and the society, it is going to lead to the drug-resistant infections. So whenever we are going to use, one need to consider benefit versus harm of antimicrobial therapy and indirect adverse events like through the more senior like Clostridium difficile, and we all know that antibiotics can lead to. So this is one beautiful document from Australian Healthcare. They have tried to look into the number of drivers, including behavior, and I think we need to follow these. And briefly, I'm going to talk about. They have these three very important studies, like emotional, cognitive, social factor, antimicrobial prescribing. And unless we are going to take care of these psychosocial factors, the prescribing behaviors are not going to improve. Then there are certain enablers. So this is handshake stewardship. What does it mean? That we need to talk about in the team. We need to talk about take care of the fear with our junior faculty and consultants, that how they are going to use. And it has been shown that perfect handshake is going to hold the key to success to the sustainability of AMS programs. Another important is that we need to look into the knowledge, awareness, and attitude, especially in the surgical facilities, and we need to identify the surgeons. So incorporate core elements, recommendation and principles in the current stewardship clinical standards. Idea is to have standard guidelines, which are going to, one can refer at times. And this is one beautiful document, one from Australian Care, where they have talked about that how they are going to, one is going to prescribe and going to take care of this. So there are certain strategies in pre and post prescription. One need to be careful, like in formulary management, and we need to have a restriction in the system that if we are going to use those aware antibiotic, reserve antibiotic as per the WHO, then there need to be guidelines and they need to be monitored. And education both for patients, doctors, nursing staff, and the society. And at the same time, we need to have the selective reporting of susceptibility testing, and those antimicrobial resistant pattern need to look into. And finally, IV to oral switch, which is not done at the most of the times. So remember, this antimicrobial steward sheet is not for hospitals. Community is also to play a role because they should not be demanding antibiotic for cold and flu or shared decision making. Finally, it's very important for all pharmacies that they should be opening only symptomatic support for cold and flu and not the antibacterials. And most of the time it happens that patient come to us, that's a leftover medication has been used. Now the patient has not improved. So we are brought him to the hospital. So because old antibiotic medicines are not discarded, and for industry, it is important to look for invest in research and development. So it's very important to look into certain practices that what are the best practices, antimicrobial prescription general practices. There are a number of documents available even from ICMR we need to look into. And most importantly, when we are going to take care of these antibacterial, it becomes important that we take care of pharmacokinetics and pharmacodynamics, because we all know pharmacokinetic is what is the drug is going to do the body, and pharmacodynamics is body's clinical response. So it's very important that for each drug we understand the relation between pharmacodynamics with that respect to the drug dosing. So what does it mean? The imperative is to deliver the correct drug for the bug at the correct concentration and to the site of infection. Because in meningitis, I can't use CNS infection, intramuscular medication is not warranted. Or like for in subacute bacterial endocarditis, we would like to have 24/7 values. So these are basic principles. And it has been shown, at least in from Australia, that most of the time the nurses are underutilized. So we should be talking about nurses and midwives to play an important role in antimicrobial stewardship. And there are certain myths regarding allergy, that antimicrobial allergy is lifelong. Is not so. And all childhood resistance with beta-lactamate antibiotics are due to allergy. No. So child may be having some viral infections, and all documented antimicrobial allergies are not true allergies. And spellosporin cross-reactivity in patient allergic penicillin is around 10%. So finally, how we are going to take care? Teamwork is the issue here. And at the patient level, what we are going to do, optimizing antimicrobial therapy by recommending an appropriate antimicrobial doses and duration, and whenever feasible, recommending IV to oral switch. And in certain situations, like with vancomycin, one need to look into the therapeutic drug monitoring, and we need to talk about to the patient to explain. And at the system level, all of us need to have a AMS program in place. And during rounds, it is suggested that all facilities with indoor facility are going to have AMS ward rounds with an infectious disease. And what is the key? Communication and collaboration and discussion with the patients and the families. And finally, to everybody should make an ongoing effort that to optimize antimicrobial use to improve the patient outcomes. So how it can be done? So we need to engage, educate and empower both our colleagues, patients, parents, and the nursing staff for this. And important is to use which empiric antibiotic which we are going to use, and these guidelines need to be updated on regular basis. And based on this, like we have definite guidelines for all bugs, they need to be used on that. So what are the solutions right now? Stewardship and prevention and control of nosocomial infections. So how we are going to cover those? Choose an antibiotic. We have to look for spectrum of coverage, patterns of resistance, evidence of track record, and how much values is achievable in serum, tissue, or body fluid concentration, and like which particular antibacterial I'm going to use in cerebrospinal fluid and urine, how much it is going to be available, allergy, toxicity, and adherence and convenience, plus the cost also. So most of the time it has been shown that 85% of the patients are given empiric therapy, and this starts with a broad spectrum or multiple drugs. So what we need to look into directed therapy, which should be an aim, but it is just prescribed in around 50% of the patients with a narrow spectrum. Evidence usually less adverse reactions, it is less expensive, and there are less chances of antimicrobial resistance. But there are certain situations every time we cannot go for less prompt therapy. So it is recommended that certain infections like limb or lifelong therapy infections. And at times we all know that in pneumonia, sinusitis, cellulitis, otitis media, we do not have cultures which are going to guide us. Then negative cultures, despite all efforts, if they are not being collected. And most importantly is the provider belief, because most of our colleague will fear of error or missing something, and they believe they will be believing that culture data is unavailable, and patient is really very sick, so he should be given 2 or 3 antibacterials, and for double coverage like for gram negatives, and if you keep using XYZ, then the patient will better. So there are certain basic principles. We should be trying to look into the infection, try to look the site, microbiology and pathophysiology. And it's important to recommend that we obtain cultures, and facilities are available, then we should be using imaging, rapid diagnostic, because they are going to help us in multi-drug bugs. So we can take appropriate therapy, and if there are special procedure which can be taken, and we need to have the right courage to make a right diagnosis, and should not be solely relying on response to therapy and following the recommended guidelines which are available in number of documents. And if the situation warrants and empirical therapy is started, then this need to be reassessed at 48 to 72 hours, and then try to de-escalate or streamline the therapy. Similarly, for outpatients, recommended to use a narrow therapy, because that has got good supporting evidence, like for pneumonia or sinusitis or otitis or media. Amoxicillin is the best drug, and if depending upon the previous uses, amoxicillin or clofenic acid. And for simple first generation cephalosporins or clindamycin, and for skin and soft tissue infections, topical antibacterials are going to give very good results. So it is a multifaceted response. Everybody need to chip in, and primary goal of stewardship is to optimize the clinical outcome. So we need to do audit, formulary restriction, in secondary strategies, education, guidelines, de-escalation, dose optimization, and IV to oral switch. So what is important to have is update, integration of rapid diagnostic testing, and the guidelines need to revise for febrile neutropenia, then dose optimization, because for the sick patients, we would like to give infusion of beta-lactams. And finally, diagnosis provided or confirmation, drug selection, 5Ds, dose optimization, de-escalation, and duration of therapy. So these are the documents which are available. We need to take care of them. And then there's a strategy like MindMe, because this is antimicrobial stewardship in nutshell is a balancing act with stewardship. So we need to look into the importance of appropriate antimicrobial therapy to the risk of toxicity and adverse reaction. So what is MindMe? This is microbiology guide therapy wherever feasible. Indication should be evidence-based. Narrow spectrum therapy should be recommended, and doses should be individualized to the patient and underlying condition, appropriate site and type of infection, and the duration of therapy has to be minimal, and wherever appropriate, we should be ensuring the monotherapy. That is mind-wheel concept. So these are more suggested techniques. And finally, rapid diagnosis. And if my patient is not going to improve, it is imperative to evaluate those patients for non-infectious sources of fever. And whenever we are taking specimen for culture and susceptibility testing, they should be obtained in appropriate manner and in the recommended directions. So pathogens, consider colonization versus infection, rates of antimicrobial resistance in a particular place, combination, and initial therapy if it is broad spectrum parental at appropriate aggressive doses. So finally, de-escalation after having the culture and susceptibility test result, narrow spectrum antimicrobial, appropriately aggressive doses. And as I discussed with you, we should be considering the pharmacokinetics and pharmacodynamics, including the age, organ dysfunction, if there are drug-related toxicities, and whenever feasible, use of less expensive agents. So why should we moving from IV to oral switch? It improves the patient comfort and mobility, also reduces the exposure to nosocomial pathogens through the IV site. There's decreased risk of phlebitis. Preparation administration time is reduced. Length of stay is also reduced, and cost finally, which is a very important factor. So evaluate for changing what we need to, and whenever it is warranted, then we need to monitor the CNO drugs. And if patient is, when we are failing with the therapy particular, then it is recommended to evaluate the patient for unidentified or new source. And then we should be ordering for additional specimens, and then evaluate the drug regimen which we are using. And if not, then finally consider the emergence of antibiotic resistant certain pathogens and evaluate the drug regimen and consider PK and PD finally. So what should be recommended? Short course I desired over long courses, and in patients with no documented pathogen, discontinue antimicrobials, so minimize the resistance of antibacterials. So these are few studies which I have taken, but for want of time, I would just like to go that we need to have an feasible and ID team, this including of ID physician, clinical pharmacist, infection control members, microbiology, epidemiologist, staff and residents, and from the pharmacist and therapeutic department, because they are all are equally important and they should be sitting across and having those antimicrobial rounds also. So what is going to do in the end of the day? Reduce emergence of antibiotic resistance, reduce drug-related adverse events, cost and mortality is also coming. But let's talk about ICU because this is a very difficult area. So because we all know it's a rapid turnover, very busy environment. So most of the time, because of the fear of missing an infection, we are going to have liberal use or overuse of antibacterials and lack of time for follow-up. So who is a steward? It takes everyone, including me, you, whosoever is working in hospital setting. Prescriber who only use antimicrobial when necessary. Clinical team use the antigram wisely. Then prescriber we use clinical pathways for assistant on treatment. Then staff who refer to the antimicrobial stewardship bedside for educational and guidance. And nurses who assist the team with intervening. And pharmacists who ensure drug dose and duration are appropriate. So these are the resources where we can visit all these and take help of these antibiogram, clinical pathways, how we are going to take care. So in the end of the day, I like to thank you all. So no action today, so no cure tomorrow. So everybody has to chip in to combat the drug resistance. Thank you. And over to
Thank you.
Nitisha.
Yeah. Thank you very much, Dr. Ashwini. May I request Anavita to please give her expert comments and to sort of add anything if she wants to?
Good evening, sir. Thank you so much for inviting me and all those humble words. This was a very, very comprehensive presentation, Ashwini sir. I think I couldn't have emphasize the role of antimicrobial stewardship and the developing resistance more precisely. So what we are facing every day is not just horribly multi-drug resistant bugs, but the fear of not being able to treat them with one or two antibiotics. So the use, misuse, and abuse, the lines have blurred out, and there is rampant use of antimicrobials. And within 1 or 2 days, every day, the antibiotics are being changed in ICUs. So, like sir said, that in emergency, especially when there is high turnover of patients, what happens is you see a patient today, he is not so sick. We start with the lower range of beta lactams. The next day, counts have increased, the fever has worsened. We suddenly shift to carbapenems. The next day, patient is having respiratory distress, the shock is worsening, the counts are increasing, the relatives are creating pressure, and then the antibiotics get further escalated. So this not only causes therapeutic failure in the patient, but gives a full opportunity for the bugs to develop antimicrobial resistance. So it is a real challenge in a practical scenario where we are bound with so much of pressure, and when we are bound with dying patients around to which tempts us to use high-end antimicrobials, but we need to be aware of its consequences. We need to be aware when not to, more than when to escalate. And a collaborative approach with all stakeholders is something which is very important in such a scenario. Having a thorough communication with a microbiologist as to what the culture reports are indicating, so that we can de-escalate timely, so that we can escalate appropriately. There are multiple aspects, and sir covered all of them beautifully. But sir, I would want to ask you, what are the practical challenges that you're facing at your center in a NICU, and how do you practically deal with them?
So most important is that I'm not confident my colleagues. So as you rightly said that the antibiotics are changed, I'm not going to give a particular set of antibacterial to act for 48 to 72 hours.
Exactly.
And then they are escalated at 24 hours. And let me be with you, because some institution, we are getting patients, referral patient from UP, where the daily CBC done, and then they are going to take a call. So I think we need to cut that practice also, that daily CBC, and based on that, I'm going to take a call. And especially what I've seen with my few colleagues in neonatology, just based on platelet count, they are going to escalate the antibiotics. You must be also aware of that practice. So that's
Yes,
again, so end of the day, what happens, as I shared in one of the slide. So because of this plasmid mediated
yes,
response,
sir.
this transmission, so
Yes, sir.
ultimately the whole of the bugs, because now I'm facing the same issue in my nursery. I'm getting Klebsiella acinetobacter
Everywhere.
only sensitive to cholesterol.
Right, sir.
So we basically has forgotten about the cleaning of surfaces, hand washing, and use of appropriate antimicrobial practices.
Absolutely right, sir. And for the next generations, this is going to be a very, very massive challenge, because the kids who are currently literally being washed with such high-end antibiotics, when they're going to grow up, their antimicrobial resistance within themselves is going to be sky high. Plus, their gut microbiota would have already developed so much of resistance that it would have led to multiple disorders. As we can recently go through the literature, the gut microbiota is so important in various developmental issues that develop later, various autoimmune disorders, metabolic disorders, and so many things. So imagine all these kids who are being washed with such high-end antibiotics right now. God knows what are they going to grow up 20 years later. In what kind of a scenario would they end up be?
You are absolutely right. I think we need to keep that factor into, because now we have got many evidence in the literature.
Exactly, sir.
Yeah.
So it's a very dreadful scenario that we are facing, with the lack of antibiotics to choose from that currently we are facing. So, if I may ask, are you seeing pan-drug resistant Pseudomonas, even colistin resistant Pseudomonas in your institute?
Fortunately, we are struggling only with Acinetobacter,
Okay.
and Pseudomonas is very, very less.
Okay, that's
Yeah.
really good to hear. But in
Yeah.
our institute, so we are seeing pan-drug resistant Pseudomonas. It is resistant to colistin. It is resistant to Zavicefta-Astronam combination. It is resistant to all the other antimicrobials. And it's not one or two odd patients that I'm talking about, sir. This is multiple patients, and because of plasmid-mediated resistance, and in Pseudomonas because of multiple ways of resistance mechanisms, it just spreads. And we recently had an outbreak in our general ward where the hygiene and hygiene practices are absolute at a loss. That there were 5 patients who developed pan-drug resistant Pseudomonas UTI, probably because of the Foley's insertion with poor hygiene. And
Yes.
it was a nightmare to treat those patients. And we are moving ahead towards such a future, and we have no antibiotics to treat them with.
Sorry to interrupt, Dr. Anivita. Were these adult patients or
Yes,
pediatric?
ma'am. So it started off, these were adult patients that I'm
Yeah,
talking about,
so
ma'am.
we have the
It,
same scenario at our hospital at Max Patparganj.
oh my
There
God.
is pan-resistant Pseudomonas reported quite a bit in the adult ICU, but not as yet in our pediatric ICU. So that's at least
An early warning, actually, we need to tighten up our belts, everyone.
Definitely,
Thank you,
sir. And
Professor Sood. I think that was a very extensive and comprehensive talk and lovely comments from you, Anivita. Were you saying something else? I think I interrupted you. Please go ahead.
no, ma'am. No, ma'am. That's all. I was just saying that thank you so much, sir, ma'am, to highlight this very important, pertinent issue. We are going through a very major challenge of antimicrobial resistance with lack of antibiotics. And all that all of us can do is, like sir said, educate, ensure, and empower. That's what
So
we need to do day in, day out.
I just
And
wanted to
first
add a few comments
yeah.
that I feel that there should be a lot of emphasis on antibiotic stewardship and correct antibiotic use in our undergraduate curriculum. As undergraduates, if doctors are primed, that will really pay off in the long run. That's point number one. Point number two, even when you start practicing, it's important to constantly attend CMEs and such beautiful talks like these so that you stay updated and you're not scared when you're writing a prescription in your clinic. Remember, all bugs do not need drugs. So if at all you've seen a child, examine the child, stop, think, and only then think of writing an antibiotic. Don't come under pressure by the person sitting in front of you, the parents, or your own, you don't have time, so you quickly want to scribble an antibiotic and finish it off. And in the IP scenario, in inpatients, it's important for hospitals to start working on some sort of an antimicrobial stewardship program, which is constant all over the country. Hope there will be political will in the coming years because we now know that WHO says AMR is one of the top 10 global threats to the human population. So once you have an antibiotic stewardship program set in place in hospitals, definitely things will get little better. You also need such diagnostic tests which on the bedside of an ICU patient give you quick results in a few hours as to what is the etiology, what is the susceptibility. And that would be truly a win. Once you have such a POC test or you have a test which quickly gives you answers, something like Molditov or Babian, and even further improvement, which is much cheaper and can be applied all over the country, that is the time when antimicrobial stewardship will actually work a lot on ground. This month or next month, the Longitude Prize will be it will come out, and Longitude Prize this year is being given to an innovation in AMR, a test, something which would quickly diagnose the etiologic organism. So I think let's end on a positive note that good things will come in the coming months to years. And comments from Dr. Anupam.
Sorry, can just a second. Yeah. Tapisha, I think we have Dr. Pankaj Garg in the thing. Pankaj, would you like to comment and wind up the whole thing?
That's very nice of you, Dr. Nupam, to ask me for my comments because we are also in the same boat, and even in the ICUs, we do see patients who are multi-drug resistant. And because we are dealing with the most smallest and most sickest of the population, there's always a scare in the mind of a neonatologist to stop an antibiotic if it is going on. So मैं एक बात बोलता हूँ अपने सभी रेजिडेंट्स को कि एंटीबायोटिक बंद करना धर्म का काम है, and I really mean it, because ultimately when you make rounds, the most discussion on the round happens on antibiotics, whether to start, whether to continue, whether we should cut down the duration. We have done some research in our department also, when we have used antibiotics for 10 days in place of 14 days, even in gram-negative sepsis without meningitis. And I'm sure that all of us can do some work in that field to cut down the number of days of antibiotics, even in those situations which have been written in books like 10 to 14 days, 14 to 21 days. Most of them are still empirical. Most of them lack hardcore evidence to suggest their duration of treatment. So not only we should be very cautious of starting antibiotic, we make it sure that if an antibiotic has been started, cultures are negative within 36 hours. In newborn sepsis, now the cutoff is not 48 hours, which used to be. It's 36 hours after starting antibiotics. You have to decide that we want to stop it if the cultures have coming negative. We believe our cultures a lot, which I'm sure with the advent of better technologies, cultures are the most important diagnostic the thing which will help us in saying that this is not infection. So thank you so much, Dr. Ashwini and Dr. Anvita and Dr. Tapisha, for highlighting all the important points. And this has to be like a fight against bacteria, against resistance. And all of us have to combine our efforts. Only then we can win this war. Thank you so much.
Thank you, everybody, and good night.
Good night, sir. Good night.
Thank you, Dr. Sood.
Thank you.